Thank you for joining us for the Parenting at Mealtime and Playtime webinar. The Ohio Chapter, American Academy of Pediatrics, operates this program with the financial support of the Ohio Department of Health. The Parenting at Mealtime and Playtime program, also known as PMP, has continued to evolve over the past several years to offer the best possible resources to you and the families you serve. Today we are excited to share more information on the programs in Ohio. We're excited to share the information from Dr. Chris Bowling, a pediatrician from Cincinnati and the current chair of the section on obesity with the American Academy of Pediatrics. Dr. Bowling will discuss how to motivate your clients and families towards positive change with sensitivity and compassion. The speaker has no financial relationships to disclose, and no off-label products will be discussed. The Parenting at Mealtime and Playtime program is here to assist you in your discussions with families. We aim to provide tools that will make your interactions more meaningful in the limited time you have with them, and contribute to positive, healthful behavior change. In order to access our resources, we recommend you visit our Ohio AAP website. This is the easiest way to access PMP materials. This is available for all public health professionals at no cost, and no login is required. When you visit the website, www.ohioaap.org/PMP resources, our mobile app has other resources that may be helpful for you or your clients. This mobile app is free for download in the App Store or on Google Play. When searching for the app, search for Parenting at Mealtime and Playtime, rather than PMP, to be sure to find the correct mobile app.
Hello, my name is Chris Bowling. I'm a retired general pediatrician from Greater Cincinnati, and I'm here to speak to you today about motivational interviewing and your use of it in practice. This is on behalf of the Ohio chapter of the American Academy of Pediatrics. Our objectives today are pretty simple. We're going to list the 4 fundamental processes of motivational interviewing and explain when to use motivational interviewing, or MI, with parents and when to use MI with patients. We'll also learn a little bit about motivational interviewing-based tools. So when we talk about motivational interviewing, what are we really talking about? Well, we're really talking about behavior change. And what's the central issue of behavior change? It's the concept of ambivalence, or as we like to call it, the balance of change. And what I mean by the balance of change is a natural tendency that we have to determine whether or not we're going to follow an action. It's a natural human tendency when someone tells you to do something for you to say, well, what if I do the opposite of that thing? Ambivalence is not resistance necessarily. It's just questioning of authority, but it's also questioning of what the person has just recommended that you do. It's a normal human reaction, and it's one that we as providers need to be aware of when we're talking to our patients about behavior change. It's important to remember that it is always about change. We don't use motivational interviewing when we're just gathering information. There's a purpose to when we're using motivational interviewing. We have a bit of an agenda that we're trying to get our patients healthier. But it is collaborative in the sense that it is not just dictated by the provider. It honors the patient's autonomy. It's evocative, meaning that the decision to change, we acknowledge, resides within our patient. Motivational interviewing uses specific skills to accomplish behavior change, and it's very goal-oriented. By being goal-oriented, we also mean that it's very specific in the targeted behavior. Motivational interviewing is also about speech. MI attends to speech and what the patient is saying, both in the way they say it and the particular words that they use. In specific, MI responds to change talk or stated desire to change behavior by the patient, or resistance, that is, resistance to change any behavior recommended to them. We also talk about 4 fundamental processes in MI. The first process is engaging, or the relational foundation. MI is a person-centered style of communication. We're there to listen and understand what's going on with our patients. We really need to ask questions about where they are and what's important to them. The basis of engaging is giving yourself time to really get to know your patient before you start engaging with behavior change. MI also has a guiding principle and process to it. There is a bit of an agenda that's set collaboratively with the patient, and before that agenda, we also need to find a focus for the behavior change. There is some information that is provided, but it's not really advice giving as much as it is provision of information and exploration of what the patient wants to accomplish. A third fundamental process of MI is evoking. And what this is, we call it sometimes the transition to actual MI. And what we're doing with evoking is we're exploring with the patient what is important to them. We're using their own internal values and motivations to bring about behavior change. The decision in favor of behavior change resides within the patient and not the provider. And this is the key part of the evoking process. The fourth fundamental process is planning. And while planning may be very specific, and there is some negotiation with this plan, we really want the plan to be a collaborative agreement between provider and patient. If we had to boil down a simple, pragmatic practitioner's definition of MI, what would it be? Motivational interviewing is a person-centered counseling method for addressing the common problem of ambivalence about behavior change. I often get asked as a provider and as a motivational interviewing provider, is MI really for parents or is it for their kids? With the pediatric population, it's more about parents and parenting style when kids are under age 6. Parental control is fairly complete at that age. However, at primary school, kids begin to exert their own control. By the time kids are 12, pretty much all of the decisions are being made by themselves. So the age between 6 and 12 is a bit of a hybrid. So if I had to say it simply, under age 6, your MI is primarily directed toward the parents. Between 6 and 12, it's sort of a combination of patient and parent. And over age 12, it's pretty much with just only the patient. Today we're going to learn about several MI tools: open questions, reflective statements, the readiness ruler, Elicit-provide-elicit, and we're going to learn a lot more about change talk and sustain talk. With change talk, a patient expresses statements that indicate they are open to behavior change. These are your moments when you want to act. These are your signals that this is a patient who may be willing to change behavior. If a patient is very resistant to behavior, giving you a lot of sustain talk, they may not be ready for later stages in motivational interviewing. It's useless to plan behavior change with someone who doesn't even view it as an issue or someone who doesn't feel empowered to be able to make the change. So it's important to be thinking, when a statement is directed back to you when you're asking about behavior change, is this change talk, meaning they're ready to do something, or is this sustain talk, where they're defending their current behavior and there's little likelihood of them changing? So let's talk about our first skill. What is an open question? Technically, an open question cannot be answered with a one-word response. Most often, we talk about an open question not being able to be answered with a yes or no response. For example, a closed question would be something along the lines of, "How old are you?" or "Have you ever had an appendectomy?" Open questions, on the other hand, require you to give more details. They should allow for a fuller, richer discussion. They are non-judgmental. Often, when a question has a yes or no answer to it, there's often a desirable answer. For example, do you smoke? And we all know that the right answer to that question is no. However, with an open question along the lines of, what are your feelings about smoking, may give you a better insight to where the patient is with smoking. Open questions allow the person you are talking with to think out loud and really conjecture about what things mean to them. It allows them to do most of the talking using their own words, and it also implicitly lets them know that the conversation is about them. There are some helpful starters that we can use to make sure that we are asking open questions and not closed questions. You could say things like, "Tell me about." "To what extent?" "What else?" "Help me understand." "How did you?" And what, if any? A second tool and probably the central tool of all motivational interviewing is reflective listening, or reflections. Reflective statements and reflective listening really lets the patient realize that you get it. It also evokes their internal motivation for behavior change. So what is a reflection or a reflective statement really? A reflective statement reflects, like a mirror or a parrot, what people have just said or what they are feeling. It shows that you want to understand what the person is saying and lets you check to make sure that you are accurately understanding what they are saying. It opens the door for people to keep talking. You can reflect a lot of different things with a reflective statement. You can reflect content. For example, you can just sort of say back to them what they just said to you. You can reflect a feeling, like obviously that must make you sad or happy. You can reflect meaning, saying something like, wow, by that happening, I bet this really meant blank. You can do what's called a double-sided reflection, and we're going to talk about that one in more detail in just a little bit. You can also do something called an amplified reflection, which we'll also discuss in more detail. Let's practice some reflective statements with a very simple trigger question or trigger statement. If someone were to say to you, "It's sunny outside," you could reflect just basically what they just said to you. Yes, the weather really is nice today. You could also reflect what "it's sunny outside" might cause them to be feeling. Well, this spring weather really makes you happy. You could reflect something about the meaning behind their statement. When they say "it's sunny outside," you could respond, "You must be really excited about getting your triathlon training going." Or, for example, a double-sided reflection might be something like this. On one hand, it's great to see the sun, but on the other hand, I know how much you despise yard work. An amplified reflection requires a little bit more explanation as well. This can also be called siding with the negative or coming alongside. You have to be careful with these because done poorly, they can sound almost snarky or confrontational. Let's take an example. Your 16-year-old patient who won't stop smoking marijuana says to you, "I'm not quitting. It's safer than alcohol and it helps calm me down." What can you say that would be a response to this? This might be a great place for an amplified reflection. Rather than lecturing the patient about the dangers of marijuana or saying that they're going to get in trouble by smoking marijuana, you could say something along the lines of, "There must be something about smoking marijuana that is really helping you." Or, "It sounds like, in some way, marijuana is filling a very important need for you." It avoids confrontation and allows you to move alongside them so they might then argue for change on their own. The next tool I'd like to discuss is one of my favorites in MI. It's called the readiness ruler. It's a great tool that really gets to the heart of the issue of ambivalence. It's important to remember with the readiness ruler, there are two aspects to it. There's importance and confidence with the behavior. And these concepts are different. Importance answers the question, why should I change? Confidence refers more to self-efficacy, meaning, can I change? Can I do it? How will I do it? Who will help me? And importance and confidence together make up readiness. If we talk about this a little bit more, let's say that my behavior change is stopping drinking alcohol. I first have to determine how important is it to me to stop drinking alcohol. If I don't see drinking alcohol as a problem, it's not very important for me to stop. It's a very different question than the confidence question. I may really want to stop drinking alcohol and know the importance that I do that. However, I may have no confidence at all in knowing about how to accomplish that goal. So importance and confidence both must be assessed before you can move on when you're using the readiness ruler. So if we think about the readiness ruler as an actual ruler from 0 to 10, I can ask someone, how confident are you that you could change that behavior if you decided to? Or I could say, how important is it that you change that behavior on a scale from 0 to 10? In general, and this isn't validated, but in general, if someone says that the level is greater than 7, they're probably ready to move on to some sort of change plan. What does the ruler really elicit? Well, when someone gives you a number, you then ask the questions, why not higher? Or why not lower? When you ask higher, what you're going to get back is is the patient arguing for why the behavior is important or why they're confident in changing behavior. It helps them argue for change. When you ask why isn't it a lower number, what you're going to get is the patient expressing barriers to change, why it's not important to them, why they are not confident in changing that behavior. So what happens as a provider if you decide to do confidence first? It might actually cause problems because someone may be very confident in their ability to change a behavior, but they just don't view it as important. So it doesn't really make any sense to talk about someone changing a behavior if they have no intention of doing it because they don't think it's an important behavior change in the first place. And as we said, when we talk about higher and lower numbers, we can start eliciting things that empower patients, and we can also identify barriers that we might need to address with this behavior change. Let's talk a little bit about how this might work in practice. I always think it's helpful if we talk about specific cases. So let's do it in that way. Let's consider Ashley, who is a 9-year-old in for her well child check. Ashley is at the 50th percentile BMI for age and gender. Being 9, it's time for her routine non-fasting lipid screening in the office. Her cholesterol is normal, but her triglycerides are elevated at 170. In discussion, you find out that she has been drinking apple juice in excess of 24 ounces per day on average. And you may remember that triglycerides are affected by intake of simple sugars and intake of fats. In identifying her apple juice as a potential behavior change, how can you use MI and the readiness ruler to discuss this behavior juice intake as a behavior change? And with your assistance and guidance, you've gotten her to that point. So now you ask Ashley, so Ashley, on a scale of 0 to 10, with 0 being this is not at all important to me for my health, and 10 being this is one of the most important things in my life, how important is it to you to quit drinking apple juice? I'd like to make a little aside here. Some people will ask, how young can kids really do this? I would encourage you to try this with your patients. I am consistently amazed at how young kids can figure this one out. They seem to have no problem with a 0 to 10 scoring system, and they really seem to grasp this one pretty well. So on questioning, Ashley says, Dr. Bowling, I think it's probably a 5. To which I could say to her, Ashley, saying that it's a 5 is great. So tell me why it's not a 3. At that point, Ashley might say something like, well, I really know that we've been talking about nutrition and exercise a lot over the past visit, and I think I really know that this apple juice is not good for me. Mom's always yelling at me, so I know it's important for me. And then I could say, so Ashley, why is it not an 8? She might say something like, I really like apple juice and I don't want to get rid of it because it's important to me. It's something I do with my friends. We can then say to her, Ashley, let's talk about this a little differently. So let's talk about how much you think you could be successful at stopping drinking apple juice. 0 is, there's no way, Dr. Bowling, that I can stop drinking apple juice. I love it too much. It's 0. And 10 being, oh, that would be easy for me to stop. I could stop right now if you told me to stop drinking it. So where would it be, Ashley, from 0 to 10? And at this point, she says, you know what? It's a 3. So knowing that her confidence is very low, your natural tendency is immediately to go in and attack, oh my gosh, what's holding you back? What are the challenges? But I'd ask you to pause and say something along the lines of like, so Ashley, why is it not a 1 or a 2? And she might say, well, I kind of like lemonade and I kind of like water and I kind of like flavored waters. So that might actually be an opening that you think we could go with later. And then you could also follow up with the other question that we all leap to. Why is it not an 8 or a 9? And then she might say, I really like the taste of apple juice. What else would I drink? I'm not that crazy about other things. So by going under first, we hopefully will get Ashley to argue for change. One of my absolute favorite tools in teaching motivational interviewing is the technique known as Elicit-provide-elicit. As medical providers, we love to give advice. And I'm here to tell you that our patients don't take our advice very often. Elicit-provide-elicit allows us in an MI sort of way to provide information and not give advice, but get their reaction to that information and then move forward. So elicit-provide-elicit occurs in 3 steps: elicit, provide information, and elicit a response. It's a synthesis of MI skills where you'll use open questions and reflective statements along the way. Elicit-provide-elicit provides a limited amount of material in bite-sized pieces in the spirit of MI. It's not advice giving. It's information giving and figuring out a reaction to that information. The amount of advice, as in not very much, is critical in an elicit-provide-elicit cycle. Frequent mini repeats are preferable to one long session. We often say that elicit-provide-elicit is like a sandwich, with elicit segments being the bread, provide being the meat in the middle. And these are finger sandwiches, not foot-long submarines. So what does this really look like? Elicit might be something along the lines of, so what are your thoughts about watching less TV? Provide might be something along the lines of first asking permission and then providing a small amount of information. Well, we know, may I provide you some information on screen time? And when they say yes, if they say no, you need to stop, obviously. But if they say yes, which they almost always do, you can say, what we know is that people who get a lot of screen time have worse health outcomes than people who don't. And then it's important to finish up with your third step, which is the elicit at the end, saying, so tell me what you thought about what I just told you. There are several essential pieces to an EPE or elicit-provide-elicit cycle. Ask permission in that second step. This one maneuver of asking permission to provide information is tremendously helpful. Asking permission often takes people off guard. It allows them to really know that you're listening to them. And it's incredibly affirming and promotes conversation. You really want to give small pieces of information, and I can't really stress this enough. When we give a big, long sequence, people glaze over. We want to know what they think about a small piece of information, provide it to them, and get their reaction. Always ask for a response. Again, I always think that doing MI is best when we talk about it with actual patients. So I've got another case study to talk with you about where we can kind of highlight some EPE cycles. In this case, we're talking about Carrie, who is the mother of 13-year-old Sabrina. Now let's talk about her, about Carrie, not Sabrina, but Carrie. Carrie has a history of severe obesity, and after bariatric surgery 10 years ago, Carrie has maintained a BMI of 20. Sabrina, her daughter, has always been over the 85th percentile BMI since age 4. And Carrie's been very concerned about that because of her history of severe obesity. People always say Sabrina looks just like you, Carrie, and you must think you're seeing yourself grow up again. Well, over the last year, Sabrina has become very conscious of her weight and, in her mother's words, finally started listening to me about her weight. When you get Carrie out of the room, Sabrina confides in you, with her mother not present, that she is skipping meals and she still feels fat, even though she has now dropped below the 10th percentile in BMI for her age and gender. You are concerned because she is demonstrating signs and symptoms of an eating disorder. This is big stuff. Let's use MI to approach this touchy subject with Carrie, who is happy that Sabrina has finally gotten her weight under control. Please notice, I'm not using MI with Sabrina in this case. Eating disorders and disordered eating are very complicated, and really MI is there for brief encounters, not for long-term counseling for a patient who has an eating disorder. But let's use it with Carrie. So when you get Carrie back by herself in the next room, Sabrina is not with you, and you say to Carrie, "So I had a good discussion with Sabrina. So how are you feeling about things, Carrie?" And Carrie confides in you, "You know what? I am so happy that Sabrina is finally losing some weight. You know how I struggle with this, and I just do not want her to go through the same bullying and the same mean girl treatment that I received as a teenager. So I'm thrilled for her that she's getting so much more confident and that she's gotten her weight under control." You, knowing that there's a lot more going on here and things that you're very concerned about, need to communicate this to Carrie in a way that she can hear it. So you might say something along the lines of, "So it sounds like you're really happy with how things are going with Carrie." "Yes, I'm very happy with how they're going with her," she might respond. And you could say, "You know, Carrie, I have a few concerns. I was wondering if I could express them with you." And she might say, hopefully, "Yes, go right ahead. That's what we're here for." Well, you know, one of the things that often we get concerned about when girls, especially, but also boys, but when girls who are 13 start losing weight abruptly, we worry that they can do things in non-constructive or even dangerous ways. And then coming to the second part, the next part of your elicit-provide-elicit cycle, you could say something like, "What do you think about that?" And Carrie might say, "I don't know what to think about that. Tell me more." And you could say, do another EPE cycle saying something along the lines of, "Can I tell you a little bit about some of the behaviors that I've seen in practice with our patients?" And if she says, "Sure, tell me," you could say something along the lines, girls often, and boys too, often come up with their own ways of dieting, and that often includes very restrictive eating practices where they choose not to eat at all. What kinds of concerns do you have about that, if any, with Sabrina? Carrie might say something along the lines of, "I have no worries about that at all. She finishes her plate. I never see any problems with that." Or she may say, "You know, I am wondering about that because when we order things, she'll say that she's not hungry at that point." So what the EPE cycles are meant to do, they're meant to give you a chance to get little pieces of information to know what Carrie understands about Sabrina's issues. She may know much more than you think, or she may know very little, and you may be really surprised how early you need to start in the process. One of the complaints that people always say about MI is, "Boy, it's going to take so much time." What I would position as a response to that is MI can really help you zero in on where you need to go and prevent you from wasting time on things that you think need to have happen when really the patient can guide you right to the spot where they need help. Maybe Carrie needs help with even understanding what eating disorders are. Or maybe down deep she knows that something is going on and that she may even confide in you that she's been actually worried that she's been losing weight too quickly. As you know, I love case studies. So let's do another case study and talk about how we can use a lot of these different types of tools together in one way. Along with eating disorders, vaccine hesitancy can really be a tough area to counsel in. So I'd like to give you a case study where we're talking about vaccine hesitancy and where you might go with MI and where you might want to avoid using MI. So John is the 32-year-old father of 4-year-old Tristan, who has severe asthma. John has always been skeptical about the flu vaccine. He has stated in the past that the only time I got the flu was in the 1 year my wife badgered me into getting it. He has been reading a lot about the dangers of both flu and COVID in patients with asthma. So let's talk about how this discussion might go with John. And this is primarily going to be with John because Tristan, as we say, is 4. So we're talking with his dad. So John, I'm really glad you came in, and I'm really glad you're willing to talk about these vaccines. You know our position on vaccines and how important we think they are. And I also know that you've not been all that impressed with the COVID vaccine, especially from what you just told to me. So tell me more about this flu vaccine issue that you were telling me about. And he might say something like, Dr. Bowling, I never got the flu. The 1 year my wife talked me into it, I got the flu from it. So I just don't think it's a good idea for Tristan because I think it might be a risk factor for him getting the flu. Well, John, can I give you some ideas on that one? And he might say, sure, Dr. Bowling, go ahead. So, John, what we know is that in Tristan, what we're giving is the killed vaccine. It's a shot. It's not the live virus vaccine. This is the killed virus vaccine, and there's nothing living in it. So you really can't get the flu from it. You really can't get it from the live virus vaccine either, but there's nothing living in the shot form of the flu vaccine. So what are your thoughts on that? To which you might say, well, I didn't realize that. Maybe I just got a reaction to it. And you could say something along the lines of, well, that's true. Can I give you more information on what we think Tristan might get a reaction from? Sure, go ahead, Dr. Bowling. To which you could say, well, with Tristan in his age group, 4-year-olds tend to get very mild reactions to them. It's mostly local reactions, and if they do get a response, usually less than 24 hours with a very low-grade fever. Occasionally they get a little bit higher ones, but not very much. And you could say something along the lines of, well, how do you feel about that? John may say something like, that makes sense, or he may give you more resistance where you can explore it a little bit more. Or he may go on to say something like, okay, well, maybe the side effects aren't as much to worry about in a 4-year-old, but why should I worry about it with a 4-year-old? And then you could say something along the lines of, well, there are some specific things about Tristan that make me a little bit more worried about him getting the flu. May I share those with you? Sure, Dr. Bowling, tell me what you got. Well, what we know is that younger kids in his age group, and especially our patients with asthma, like Tristan, have a really hard time with the flu. They often get hospitalized. They often have really adverse outcomes, sometimes even death, from really bad cases of the flu. What are your considerations on that? And John would probably say something, or could say anything, but he might say something along the lines of, well, obviously, I don't want something serious to happen for Tristan, and you really feel like this might be something that would occur? So clearly, this is a conversation that might go this way and might be productive. It may not be, and you may not get anywhere further with John than he is currently. And Tristan may walk out of your office without the vaccine. However, done in a respectful way, we never know what seeds we're planting for future discussions. When done appropriately, MI should be non-threatening, non-judgmental, should be very conversational. And we find that when you do it repeatedly, patients come back. And they often come back a year, 2 years, even much later, and say, we've talked about this before. They heard you, and then they come back with a change in behavior. So I guess what I would say here is play the long game and let MI help you do that. So let's think about how you might try this out in your practice. 2 changes, just a suggestion here, but you can always go with your own ideas, is try something like this. In your families who have children with nutrition or activity challenges, use and document an elicit-provide-elicit cycle to address readiness to adopt a healthier behavior. Or, in a family where a patient has a behavior change that you've agreed on, just try using the readiness ruler. Try assessing both importance and confidence, and pay attention to see if the changes stick from one visit to the next. And I really would encourage you, if you haven't done it before, try asking for permission to give information. It is life-changing. In conclusion, practice makes perfect. None of us are good at this from the get-go. You won't be comfortable with it overnight, so just remember back to those first times you met a patient for the first time and how uncomfortable you felt. You may feel the same way with MI skills. You'll get better at it. It really represents a change to the language we use and the language we pay attention to from our patients. It should be different, and have fun with it. Don't wait for specific patients with specific illnesses to try it out. Try it out in situations that you think, this is a small behavior change, but it's a simple one. Let me try some MI here. Thank you for listening today, and be sure to reach out to us at the Ohio AAP if you have any questions about motivational interviewing or this webinar.
We sincerely appreciate you spending your time with the Ohio AAP to learn more about these important topics impacting children's nutrition and play. You can access the Parenting at Mealtime and Playtime resources on our Ohio AAP website. Thank you to our presenters for all they do for the Parenting at Mealtime and Playtime program and for Ohio's children. If you have any questions for Ohio AAP, please don't hesitate to call us at 614-846-6258. A big thank you to you for your ongoing efforts to assist Ohio's families.